welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things MS, health and wellness, advocacy, and we'll even throw a little bit of music and music therapy in there as well. Thank you so much for joining us, and stay tuned for the next episode. Hello, everyone. Happy Monday and welcome to Brain Chat. It's Dr. Mitzi, the nerdy neurologist, your host of Brain Chat. And I'm so excited to talk to you today about a topic that I think is very important, to women who are living with chronic disease, particularly women living with multiple sclerosis. But before we get into that, I'm very excited, to have my amazing guest with me this evening. And also, for those of you who've not logged into Brain Chat before, just make sure you type in the chat where you are viewing us from. I bid you greetings from Atlanta, Georgia, where it is nice and warm, and I hope that you all are enjoying yourselves today. All right, so let's get right into it. I have two amazing guests with me this evening. I've got Dr. Latoya Benita Stevens, who is an OBGYN, and she's also the founder and medical director of the Childbearing Medical Center and Spa. And then I also have Dr. Riley Brove, who's assistant professor of neurology, associate professor of neurology. Welcome to Brain Chat, ladies.
Thank you.
Awesome. Well, I'm so excited to have you guys with me tonight to talk about women's health. So it's Women's Health Month. And we know that autoimmune diseases, preferentially affect women, particularly multiple sclerosis, and even some of our other diseases like neuromyelitis optica can affect women 8 or 9 times as commonly as men versus MS 3 times more commonly as men. So I think it's important for us to recognize, some of the issues or challenges that may come up, some of the things patients may have questions about. And we just want to kind of get into it and talk a little bit about MS across the woman's lifespan, right? Because there are many changes we go through, whether it's puberty, whether it's childbearing, whether it is menopause. So we get to go through all the changes. So we're going to get into it today. But first, I want you guys to talk a little bit about, whenever I have guests on Brain Chat, I love for you to kind of share your story about what got you interested in your field of medicine. Usually it's neurologists, but I will start with you, Dr. Stevens. Tell us a little bit about what got you interested in your field of medicine and kind of what you're doing, at this point of your career.
Well, thank you so much for having me on the show. Ironically enough, I went into obstetrics and gynecology because I thought that I was going to be doing well medicine. But these days, it seems like everybody has some type of chronic illness, even at, the younger ages with pregnancy and continuing on to the menopausal years. But what I really enjoy about my specialty is the ability to help women through all spans of their life. We start with the childbearing years, and then we progress on to menopause. So a lot of these patients, I'm able to see them early in life. I get to see their mothers as they're kind of going through the menopausal stages, and then other family members throughout the years as well. So kind of seeing them throughout the whole spans of life is what has kept me interested in the space.
And that's pretty cool because as neurologists, particularly when we're treating conditions like MS, we also get to see people, kind of across their lifespan. Sometimes we see people. I saw a patient that, I had seen as a teenager, not too long ago. And so you get to see people kind of in their 20s as they're going through school and they have kids, and then all the things we get to see over time. Talk to us a little bit about your interests, Dr. Bove.
Yeah, nice to be here with you both and with you all. I actually remember being in medical school and standing at the crossroads, seeing the neurology team I'd rotated with coming down one kind of corridor, and the OBGYN team I'd rotated with coming down the other corridor, and both of them asking, Riley, did you apply in our, and I remember being really sort of at this very literal and also symbolic crossroads, because the idea of understanding how women's bodies and women's behavior sort of reflect their cultural environment, their nutritional environment, their ecological, economic environment, and how all of that is embodied in women's health, and how to support women during their reproductive transitions when they're facing a chronic condition is something that's always really spoken to me. And so multiple sclerosis really, as sort of is an opportunity to get to sort of grapple with women's health also through this whole continuum, and to make treatment decisions and symptom management decisions and life decisions at a lot of different time points, which I think is really meaningful and really interesting.
So I did not know that. So I was at a crossroads probably between psychiatry and neurology, and I wound up choosing neurology. But yeah, that's very interesting and very fitting, right, for the work that you do now. So let's take kind of a 50,000-foot view, step back, right? Why is it important to talk about women's health? I find, I spend a lot of time counseling my patients about how they always put themselves at the bottom of the list. We're taking care of everybody else and we don't take care of ourselves. Why is it important, or, what message should we be sending people about the importance of making sure that you're checking in regularly and doing your screenings and just taking care of your health, period?
Well, I think it's important for what you just said, because we're always taking care of everyone else, and we tend to put ourselves at the bottom of the list. But if you can get the woman of the family to start taking care of herself, then most of that will trickle over to the rest of the people that she's taking care of it, whether it's her parents or her kids or whomever. But if you can get that woman to kind of understand the importance of eating well, of moving more, of taking these different medications for this chronic illness or whatever, the rest of the family seems to get the big picture as well.
Absolutely. Anything you want to add to that, Riley?
Yeah, I think another bit, thinking about this as a researcher, the other piece of importance is that, we don't know about the dosing that might be more effective or more safe in a woman's body. We don't know so much about the how women and men might respond differently to treatments. We don't know about which are the symptoms that are the most bothersome or the most important to women. And, all of science, from lab rats and lab mice all the way to clinical trials, really hasn't paid enough attention to sex and gender. And so sometimes we're making really important medical decisions with patients that are going to affect, as you both mentioned, their whole families. And we don't have enough information about how to, what's the best treatment decisions for them. And so I think we're trying to take care of these people who are in the core of a family's life, the center of their whole community, and we don't always have the best knowledge for them.
Yeah. And that applies to so many groups, right? We talk a lot on Brain Chat about minoritized groups. There are a lot of groups where we need more information to make sure that we're treating people appropriately. And I love that there is so much attention now being paid to women, particularly in chronic diseases like multiple sclerosis, even though it primarily affects women. I want to switch gears and talk a little bit about childbearing, but I remember when I first came out of training, it was like, okay, we take you off your medicine and we just kind of close our eyes and see what happens. Yeah, I mean, we check in with you, right? But it was like, we just take you off and what happens, and we hope you get pregnant really quickly. But if you don't, then we have to, try to figure out what we want to do. And there wasn't really any guidance about our medications and how to potentially use them. And that has grown, I think, a lot because we have more women in the field, right? So we have more women who are
Right.
doctors, who, have a personal passion for paying attention to these things. But there really has been a great advance in, what we've seen and how we manage pregnancy in multiple sclerosis now versus how we did years ago. But thinking kind of in general about maternal outcomes, again, when thinking about pregnancy and family planning, I want you, Dr. Stevens, to talk a little bit about kind of some of the data we have just about general maternal health outcomes just in the US in general. And then I want to kind of nail that down and have you, Dr. Bove, talk a little bit about specifically what we're seeing in the MS population.
Yeah, unfortunately, in our minority community, the morbidity and mortality is like significantly increased, particularly with Black women, almost three times that of our white women. A lot of times we're seeing a lot higher rates of preeclampsia,
Mm-hmm.
postpartum hemorrhages, preterm deliveries, all of those different things within those communities. And it's unfortunate. Some of it we think is due to just um, lack of insurance, lack of prenatal care, lack of exposure to the same resources as our other counterparts. That's really playing a role in keeping the patients from receiving the care that they need. And also, it has to do with us as providers and clinicians. We have the opportunity to intervene with our patients, say that when they come to a family medicine appointment and you're hearing some of these things in their history, that's the time to send them to the obstetrician or the gynecologist and have them see us before they get pregnant so that we can kind of talk about some of the things that they're at risk for so that they don't have to wait until they're pregnant. And now that you're pregnant, we're kind of forced to just deal with what's going on with them. Having an opportunity to say, okay, if there's obesity, let's try to lose some of this weight before you get pregnant again. Or if you had a bad outcome where you had a horrible postpartum hemorrhage, was there something in your history that predisposed you to bleed more heavily than, say, the average woman? And if you had a blood clot, making sure that you're on a blood thinner before you get pregnant again. Just some of those interventions that we could do ahead of time. But because we're not seeing the patients until, they walk in the door, they're not having prenatal care as the provider. Sometimes we're just forced to deal with what's presented to us. And sometimes that's as much as we would like to help people. I think the general public doesn't understand how difficult of a situation that is when you're presented with so little information about their prior history.
So important, So I talk to my patients a lot about counseling, right? About planning for
Mm-hmm.
pregnancy, right? We know that a large amount of pregnancies are unplanned, but if you are anywhere in the childbearing vicinity, right?
Yes.
Then I like to have those conversations about, okay, what would this look like potentially, so that at least somewhere tucked in the back of your mind,
Uh-huh.
we've had a conversation about, kind of what those next steps are,
Uh-huh.
because you never know. Oftentimes person doesn't know they're pregnant until they're a couple months pregnant. You know what I mean?
Mm-hmm.
So we want to have those conversations. We want to plan ahead of time. What do those conversations look like for you, Riley, when you're talking to your patients who are talking about family planning?
Yeah, I think like you, I really want to have that proactive kind of counseling and just a touch point every single time I see a person of childbearing potential, just to, kind of just remind them that we want to support pregnancies with that are planned, and where we really have the mom and the baby safety kind of really thought out. So sometimes it's just that quick little touch point planning, and it's just like the one question that we try to teach our trainees about. Any any chance you might plan to get pregnant in the next year or two? And sometimes that's just a flat no, and then we just move on. Just let's check in about that. Life changes. When people do become more intentional about planning, then we talk about a couple different things. We talk about the burden of having a chronic condition and how
Mm-hmm.
we really need to map out sort of, someone living with a chronic condition just has a lot more in their daily life they have to do. They have to do their labs, their MRIs, their medications, and everything else. And when they're planning a pregnancy, there's two sets of things that they have to be doing in parallel. And I think that's something that we really try to kind of really put on the table. Certainly all of the healthy stuff that was mentioned for any pregnancy, kind of making sure that they're getting that information from someone. A lot of times, I don't know if this is the same for you, Mitzi, but we almost function as the primary care doctor for some of our patients until they're pregnant or until, you know, they have new medical problems, and really trying to make sure, hey, there are specialists who can, you know, kind of make sure that you're really kind of ready to go through this. So kind of really to engage them so that we can really minimize the risk leading into pregnancy. Obviously, the big thing that comes up for women with MS is the medications. And as you mentioned, the field's changed dramatically with respect to those.
Yeah. Yeah, I mean, so much that you said is definitely true. So I am also an advocate of collaboration early. I'm like, listen, you have an OBGYN, please talk to your OB, right? You know, Dr. Mitzi knows a certain amount, but please talk to your OB. And we wind up, you know, collaborating, you know, pretty closely about the different types of care. You know, sometimes patients may encounter, you know, a relapse or have issues during pregnancy. Now, by and large, many of our patients do go into what we call remission, where they don't have symptoms during pregnancy other than pregnancy symptoms, but sometimes they will occasionally, you know, have some worsening of their MS symptoms, and we have to treat that. And so I generally work very, very closely with their OBGYN to kind of coordinate care and make sure we're on the same page, you know, in terms of medications and things like that. So I think the key is planning, right? Because, you know, there are a lot of things we have to process. What kind of medications are you taking? Your MS medication? What about symptom medications, right? Is it something that you can come off of cold turkey without problems, or is it something that we need to be trying to wean you off of in preparation? You know, so all those things need to be taken into account, you know, when we're talking about family planning. Any other things that you take into account when you're counseling patients, Dr. Stevens, who may come in with a chronic condition and, you know, are trying to, you know, navigate, well, what should I do? How does that look from your side as a OBGYN?
Well, some of it is just like what you're saying, just coordinating with the different specialists. Of course, if they have a chronic condition, they also see the maternal fetal medicine specialist during the pregnancy, and they can often see them prior to getting pregnant to kind of see what that would look like, and making sure that we're closely in touch with, say, their neurologist or the cardiologist or whatever specialist is needed, but helping that woman to understand that it's not just about seeing the OB provider. You're going to have to see us, the specialist in maternal fetal medicine, plus your regular specialist for whatever disease state it is. The other thing I want to briefly mention with the mortality and morbidity is that some of it seems to be with a lack of distrust amongst patients with providers in general. And so I have been working hard with the patients that I come in contact to kind of help them to see that when you come to the hospital and you're interacting with the providers, you know, that you got to kind of give us a break, in the sense that don't come into the situation just with the perception that there's some harm that's being presented to you, because that's what I often encounter, as if, you know, we set out to harm you for that stay. Because sometimes it seems like that we're kind of working against each other. So I think it's very important to make sure that we're building that trust, that we're not coming in with preconceived notions with the patients. And even amongst us as colleagues, if I have a bad encounter with that patient, not necessarily tainting your view, because your interaction could be completely different. But if I give you a perspective that's negative, it's likely that the rest of her hospitalization might kind of go in that same direction.
That's a great point, Benita. And, I think it's so important building trust in the community, because sometimes people do encounter issues that are not necessarily related to their health or their health conditions. It's
Hmm.
just bias, right? So we all
Yeah,
have inherent biases, but
right.
certainly there can be bias in the way that, we as physicians may approach people, and also bias, from the patient perspective. We do a lot of
Hmm.
teaching here on Brain Chat and in my practice about patient empowerment, making sure that, you're
Hmm.
preparing for your visits. If you're not getting adequate care or someone's not listening to you, that it's okay to seek a second opinion. Don't just keep going in the same direction. If you don't feel like you're being
Absolutely.
heard, it's okay to switch gears and get a second opinion. So I think that all those are key points, to making sure that we have good outcomes, because ultimately everybody wants a healthy baby and a healthy mom at the end of, at the
More
end
than
of.
they know. More than
Yes,
they
we
know.
all want a healthy baby and a healthy mommy, so that is ultimately the goal. So let's talk a little bit, Riley, about medications, right? So there was a time, before I was practicing, many back in the day, as my 7-year-old would say,
Mhm.
where they were telling people with MS not to get pregnant and not to have babies, right?
Mhm.
Now that then we went through, okay, have babies, but we'll stop all your medicine and we just pray for the best, right?
Mhm.
Now we're in an era where we actively treat people during pregnancy, or we have long acting medicines where we can have the medicines working while people are trying to get pregnant. So talk a little bit about how that approach is, kind of in the real world.
Yeah. Um, I mean, so much of what you've said is really resonating. I think um, the idea of the collaborative care model and sort
Hmm.
of having a flexible model where the
Hmm.
neurologists and the OBGYNs and the MFMs and everybody's working together for each patient. And for each patient, that group of specialists is going to be different. But making sure that we communicate to optimize outcomes, I think, is really important. One of the things that you mentioned, we used to sort of just, kind of send patients on their way, go off, I don't want to do harm. So I'll just take your meds, away from you on your way out the door. Good luck. Was just, and people said that was the ethical thing to do, but it really wasn't, because if you look at the numbers in those first 3 months postpartum, um, about 1/3 of women have new clinical relapses, and
Yeah.
about one half of women have new lesions. And we don't tolerate that level of risk for anyone in the
Mm-mm.
MS world. That's sort of like that's sort of worse than just untreated, right? The risk is higher. And so it's not really ethical to send our patients on their way and wish them good luck through that, especially that postpartum transition period. So we've really been trying to figure out how safely can we treat people as close to conception as possible, understanding that conception, different, some people get pregnant right away and some people really don't and need the help
Right.
of
Hmm.
fertility specialists, right? So having a sort of really active engagement and two-way communication throughout that whole bit before someone conceives, and then how quickly can we start therapy postpartum, understanding that the patient needs to heal and that the baby needs to learn to latch and like all those things. And so I think that's where sort of active treatment has really kind of become almost the mainstay. Now, a lot of patients don't really learn about this, and a lot of patients don't have access to clinicians who've like thought about pregnancy in the last decade or two. And so I think when you said it's okay to get a second opinion, patients deserve to have these needs and get sort of evidence-based care just like they do in any other aspect of their health, and as we'd expect from
Hmm.
any for any of our loved ones. And so I do, if patients feel like they're not getting, up-to-date advice, I really do recommend that they do get a second opinion, because there is knowledge out there. There are some really nice guidelines that have been written recently.
Hmm.
And we have a couple approaches. As you know, I love sort of the B cell depletion, approach before pregnancy and after a delivery, because we know about placental transfer and we know that we can stabilize our patients. And
Hmm.
so we can really optimize that, and we can get into the weeds if you know, later on if you want. But there are a couple other types of therapies that can be used for active management to just keep people as stable as we can in this really uncertain period.
Yeah. Yeah. So I love it. I love that, our understanding has evolved, that we do have guidelines where we're able to, treat people. And again, I think it's a discussion we need to have early and often, and we need to have that in collaboration with our other specialists to make sure that we're all on the same page, and I wish we could talk about this the whole show, but we got to talk about menopause. So we got to go to the other side. All right. So, so let's talk about menopause, right? So first of all, I'm going to ask you, Dr. Stevens. So there is a author / actress / influencer businesswoman that has been talking about perimenopause and has named her menopause. She calls it Peri, and she will get on and do a live in a minute and talk about how Peri was bothering her and messed up her hair and broke her out into a sweat. What is perimenopause? How long does it last? What does it mean? Help the people. Help the people, Benita.
Perimenopause is that transition time, that in-between time where you're still of reproductive age, but you haven't quite switched over to menopause. And it is probably one of the most annoying time periods, because at least if you're not in menopause, then great, we know what to do. And if you're in menopause, great, we can fix that too. But in that middle stage, it's like, okay, sometimes your estrogen levels are high, sometimes they're low. Sometimes you're having night sweat, sometimes you're not. So I wish I had a thought of Peri myself, because she did a great job with just making it real to you. But perimenopause usually starts to happen anywhere from the age of 35 to about 51, 52, when the average woman goes into menopause. And it's characterized by just changes in those progesterone and testosterone levels. You see fluctuation with the estrogen levels. So in testing, we're not completely low, but we have fluctuations throughout the cycle that tends to cause some of the same symptoms as you see with menopause, like hot flashes, night sweats, vaginal dryness, decreased sex drive, all of those different things, mood swings, anxiety, all of the above, all the things that make you think you're crazy.
And how long does it last? Can it last? Like, I saw something, I shouldn't be Googling, but I saw something that said it could last, like, some people 7 or 8 years.
Yeah. So as far as menopause, that when we say how long it lasts, it's about average of 8 years. But in my mind, I don't really even like to use the term of saying like we're finished with menopause, because you really don't finish with it. It's not like you lose ovarian function and then the hormones just magically come back after 7 or 8 years. I mean, you're still left without those hormones. So you still have women that are actively symptomatic in their 60s, 70s, and even 80s.
Thanks for ruining my life, Dr. Stevens. Thank you.
I think we just get better at tolerating the symptoms a little bit more. So, once you've dealt with them, you don't notice some of them as much as you did. But for the way our society has changed, as active as we are living these stressful lifestyles, I mean, now you're noticing them. You're at that board meeting and you're giving that presentation, and the hot flash is hitting, and you're looking like, oh my God, what's happening? I'm perspiring. I need some water. And so you can't just continue to ignore it like we used to.
Right. Personal summers. That's what my auntie used to call them, personal summers. All right. So how does menopause affect MS? Does it affect MS, Riley?
It does in a couple ways. And, I think we can't ignore these symptoms, and also we get to talk about them now, right? Because we do have, I think you said something earlier, Mitzi, that, we have women in medicine now, and we get to say these things are real and these things matter and these things are treatable and manageable. And, I think we're here to kind of, provide that validation for patients in a very different way. How do MS and menopause, kind of sort of like collide? I think there's a couple bits. One of the there's a couple pieces. If you think again about that perimenopausal time period, and really for MS, the few years before the final menstrual period and the few years after the final menstrual period, what I see in the clinic is that patients who have been pretty steady, pretty stable, right? We've diagnosed them, we've put them on their medication, they're on a good medication that works for them. We've, optimized their symptom management, and kind of in their, 30s, 40s, they're kind of cruising along. And then all of a sudden you see them in this perimenopausal transition. And just like you said, they come in and they say, is it my MS, my menopause, or me? They say that. They say, am I going crazy? And they say something has to give. And these things, I hear them over and over again, because as the hormones are fluctuating and the perimenopausal symptoms are fluctuating, that overlaps with the MS symptoms, right? Cognition, sleep, bladder, mood,
Right.
all of that overlaps. Those are symptoms that, patients can't necessarily figure out if this is the menopausal bit or the MS bit, and usually it's together. I think the second thing that I hear a lot is a phenomenon that we know in neurology, which is the Uthoff's phenomenon, where someone gets hot, they take a hot shower, they exercise on a hot day, and all of their neurological symptoms are a little worse. They're more tingly, they're more tired. And what I hear from patients who are experiencing the hot flashes is that really just makes them overall super uncomfortable. And then I think that the two other bits that are relevant to MS and menopause are in that postmenopausal period. And as was said, female humans live a third, a half of their lifespan in the postmenopausal period, right? And in that postmenopausal period, that's actually, we have that in common with whales. So I was loving that you wanted to be a doctor. But humans, we've evolved for this postmenopausal lifespan. And so there's a lot of preventive care that hasn't happened for our people with MS that needs to happen around bone density and cancer screening and all of that stuff that's really relevant to women's health. And the menopausal period, I think, is a good time to kind of get into that and really start planning for, those healthy decades postmenopausally. The last little bit is just figuring out whether there's anything about menopause that accelerates sort of neurological injury, neurological progression. And I think that's a really hard thing to tease out. We're trying to do it in research, and it's not quite clear if there is an effect. It's not an enormous effect by any means. So people should worry that their MS will necessarily get a lot worse, but certainly symptomatically, it can really be all over the place. And there's a lot we can do to help our patients. And so again, working really closely with our colleagues who, give hormonal treatments, who treat, menopausal symptoms using a range of strategies, I think is really important.
Yeah, I mean, you guys said so much good stuff. And I think, the difficulty is I always tell my patients, I wish I could draw like a little chart and say, okay, 30% is an MS, 50% is normal, and then the other percent is, but it's just not that easy, right? Because not only are we dealing with, the chronic condition, we're dealing with, menopause, we're also dealing with other age-related changes, right? If you got joint pain and stuff, so it can be very difficult to tease out what is related to what. And so what I often counsel people is, okay, let's focus on solutions. Okay. So I can't draw you the pie chart, right? But we can potentially deal with some of these symptoms, right? So whether they're from the MS, whether they're from this, let's see what we can manage, right? How we can try to reduce these to make life a lot more tolerable, for you. So let's talk about, how do we treat some of these symptoms? I'll start with you, Benita. How do we treat some of the symptoms of menopause? What can people do to help themselves?
So, the gold standard for treatment is hormonal therapy. I know we have gone back and forth over the years about whether or not hormones are the right thing to do, but organizations like the North American Menopause Society and ACOG all support hormonal therapy for first line treatment. But we also have non-hormonal treatments. There's a new medication out called Veoza that's gaining a lot of headway, specifically for the treatment of vasomotor symptoms of menopause, which are specifically the hot flashes and the night sweats. But then you also have over-the-counter options that a lot of women gravitate to, whether it's to just kind of help with some of the symptoms itself. So different supplements, different treatments with some of our vaginal modalities that can help with the dryness that a lot of women are experiencing. So we have a vast variety of different options out there. I think the biggest thing is just making sure that patients know that they exist, because a lot of women just think they have to just deal with it, because unfortunately, men have kind of led in this area, and when they've had problems with sexual function, we have all the pills you can think of.
I was gonna ask, when is the magic pill for the
I
They
know.
ask me about it every day. When is the
Yeah,
magic pill coming out?
no magic pill for women, but hormones pretty much can get you back to feeling like you used to. I think that's part of the problem, that we've tried to use things like antidepressants and some of the other medications to help with the symptoms, because one of the names for menopause is hysteria. So we're trying to treat the emotional or mental side of it, but that's not doing anything really for some of the other issues, like the
Right.
decreased sex drive or the major night sweat that they're having in the middle of the night. So I'm happy to see that more people are talking about perimenopause and menopause and the treatments that's out there. And with the promotion of this, more and more women are realizing that I don't have to just suffer with this. I don't just have to grow old gracefully. There are some things that I can do, and I can feel comfortable with talking with my gynecologist to do this.
Mm-hmm. And so, how do you? What does that conversation look like for you, Riley, when you're talking to your patients about, menopause, and how are we going to manage these symptoms? How does that look in clinical practice?
Because it's so upsetting to some of our patients. So some people just, there's a huge cultural, nutritional kind of, heterogeneity to the menopausal experience, right? People in different cultures experience menopause in different ways. So, for women in Western countries, the vasomotor symptoms are, really huge, but some women in Japan really don't experience that at all, right? So there's a lot of cultural and individual kind of differences in terms of what the symptoms are and how bothersome they are. So, but because there's also such a huge age range, right? Like as was said, it could happen early, it could happen later. And because people with MS who do get dysregulated can be so upset, I tend to start counseling around age 45. And to just let them know, hey, we may not get here for 10 years, but I just want to put a couple things on your radar so that you don't worry. If you experience these things, we'll work through it. And so then I remind them, at every visit, hey, if any of this starts coming up for you, just let's talk through it. Again, so that it doesn't take them by surprise. And then I think just like with pregnancy, it's a time to see people a little more frequently so that you can really kind of just get a handle on things, right? So make sure that the MS is well controlled. And then if there are vasomotor symptoms, tackling those, whether it's through the hormonal therapies or for people for whom, that's not an option, Veoza or other interventions, to really get a handle on those fluctuations, because those can really make things difficult for people with MS. And then it's just going through the symptoms one by one and trying to just pick apart all the sort of the tangle of symptoms that people can experience, and trying different modalities for different symptoms to kind of try to just unscramble everything for people.
Absolutely. Yeah. Absolutely. And then I want to ask you one more question, Benita. What about lifestyle modification, right? So, we know that hormones can definitely make a difference in how people feel. In addition to that, I've also become a big advocate of, okay, we know the medicine has a role, but what are things that you can do to help yourself, right? Because sometimes people feel like, especially in situations with a diagnosis like MS, with menopause, it's like, gosh, they feel helpless, right? What can I do to help myself? So, are there any lifestyle modification things that you recommend to your patients who are going through menopause that may be helpful, in addition
We
to, medications as well?
Yeah, I always recommend changes with diet and
Mhm.
exercise. If you're overweight and you're having hot flashes and night sweats, then definitely kind of trying to get out of that category will help with it. But ironically enough, we do think that sometimes if you're on the heavier side, that you might not have as many hot flashes
So it's a
because
reason to eat cake, right? Eat cake, less
because
hot flash.
because you're getting some of that estrogen in your fat cells, and so you may not have as many hot flashes as the other woman. But just like while we're going through the menstrual cycle and how you can see fluctuations as we eat more sugar or less sugar in our diet, all of those things are some things to think about as you're going through menopause. Decreasing the hot foods, making sure that you're staying active and doing strength training, weight bearing exercises to help with risk of osteoporosis. So
Mhm.
always kind of encouraging a healthy lifestyle, just in general, so that we don't have to just be on a diet. What are some
Right.
things that you like to eat, that you just like to eat, that's healthy for you? And what are some activities that you can do that just promote greater movement throughout your day, as opposed to dreading going to that gym session?
Mhm.
So
I love it. I love it. So, ladies, that time went by really fast. I mean, it
it
went by really fast.
did.
It really
Um,
did.
it
Oh.
did, such an amazing conversation. Thank you so much for your expertise. Um, what advice would you give to women, who need to be living healthy with their MS? What advice would you give them? I know we talked a lot about, having proactive conversations with your doctor, seeking care, being open minded, um, definitely getting those screenings, right? So, making sure we're getting our mammograms, making sure when it's time to get a colonoscopy, get the colonoscopy, right?
Mhm.
All of those things. But what kind of parting thoughts or advice would you have, for the audience, to kind of, help them or encourage them to live well?
I would say that one thing that I really try to emphasize with my patients is to make sure that they understand the treatment plan.
Hmm.
It's so many times that patients come in and they have a full visit with you, and when they walk out and you ask them, what's the plan, what's the next step, they have no idea. They cannot put into words themselves what's going on with them and what the next step is. And I think a lot of times, if we can help the patients to understand exactly what they're going through, what we're looking at as far as treatment options, then it reassures them more, because they know, okay, well, today we're going to look at this medication and see how that affects you. But if this doesn't work, then we can move on to the next step. And it helps them to be able to communicate that information to their family and friends that are helping to take care of them as well. So I encourage the patients to make sure they understand the treatment plan. And if you don't understand, don't be fearful about going back to your physician or provider and asking them to clarify and help you
Hmm.
to understand what the next step is.
I love it. Riley.
Mhm. Yeah, I think I want to go back to a couple things that were said because I think they're so important. The idea of a second opinion, if you're not
Mhm.
being treated with expertise or respect, there are other doctors who will. And,
Mhm.
our patients deserve expertise and they deserve respect. I think certainly putting their health at the center because of their importance in their loved ones' lives is important, but also they're going to be living with their health and their body their whole lives.
Right.
And one of the things I do see when my patients hit their 50s and 60s is those who've been able to make lifestyle changes for the better. So, nutrition,
Mhm.
exercise, dealing with stress. We say that like they're just supposed to magically deal with it, but dealing with stress in ways, making changes in their lives. To support wellness, I think I really start seeing it pay off for my patients who are in their
Mm.
50s and 60s. Until then,
Mhm.
they were the ones who had this chronic condition and their friends didn't have the same worries. And when they hit their 50s and 60s, those who've been able to make the healthy changes actually are kind of like, friends are catching up with them in terms of comorbidities, and the patients are doing really well because we can stabilize the MS and really promote wellness. So I think really having the long game, I'm always trying to get my patients to do their pelvic floor PT, because it's not going to get better, and it's never going to be your top item on your list, right? So I think that's one that I'm always trying to say, like, please do it now. Your 60, 70, 80-year-old self will thank you for doing it now. So I think that's one that I'm really trying to bump up the list for people. But those who can really make those lifestyle changes, and I know it's hard and lives are busy and sometimes resources are really strapped, but those who can, it pays off big time in the long run.
Yeah. Yeah, such amazing words of advice, and I would say in addition, we need to seriously make sure that we are engaging in self-care, right? So self-care is this term that's thrown around all the time, but taking care of your health is self-care, and I often say that much of what we call self-care now is recovery, right? You've been through a lot and you just go on vacation for a week just to get yourself reset, right? But you're not really pouring into and building yourself up on a regular basis, so the point is to not get to the point where we're completely depleted and then we have to go, just disconnect, but to hopefully continue building ourselves on a regular basis, doing these things, going to your visits, making sure that you're engaging in lifestyle modification to the best of your ability, and then taking the vacation too, right? We want the vacation, but making sure that it's not because we're just so completely depleted and empty and we haven't been pouring into ourselves at all. So with that being said, ladies, thank you so much for an amazing episode. Dr. Beauvais, Dr. Stevens, it is a pleasure speaking with you, and I know that our audience has been helped by this information that you provided. Thank you so much for all of you who tuned into Brain Chat, and we will see you again in 2 weeks. Thank you.
Thank you.